Welcome back again, and thank you for joining us. It's my pleasure to be your host today. My name is Dr. Selma Kabashi. I'm the secretary of the African Society for Dental Craniofacial Genetics. And thank you for the regular audience and for those who are joining us for the first time. The African Society for Dental Craniofacial Genetics was established with the goal to advance research in dental and craniofacial genetics among Africans and within Africa specifically, and to promote collaboration and to share interest in the craniofacial genetics and molecular research. Today we have a special guest, and my pleasure to introduce the distinguished speaker, Professor Peter Donkor. Professor Donkor is a consultant oral and maxillofacial surgeon at the Kwame Nkrumah University of Science and Technology and Komfo Anokye Teaching Hospital in Ghana. He is a globally recognized leader in cleft care, and he is president of the Ghana Cleft Foundation and chair of the Smile Train African Medical Advisory Council. He has held numerous senior academic and professional leadership positions across Africa and has spearheaded specialist cleft and oral cancer services in Ghana. His research focuses on cleft lip and palate, oral cancer, global surgery, and medical education. So before the lecture will be entitled Multidisciplinary Team Care for Cleft Lip and Palate in Africa, Challenges and Opportunities. Just before we start, just a few housekeeping points. Please keep your mic muted throughout the presentation. There will be a dedicated Q&A session after the presentation. You are welcome to type whatever question, comment, point of discussion in the chat, and we will address it afterward. And you are welcome also to use the raise the hand tool. And the webinar, of course, will be recorded for educational purposes. You can find it within a couple of days in our society's website. Thank you, Professor Donkor, for accepting our invitation and for sharing your expertise, and the floor is yours.
Thank you very much, Salma. Please let me know if my voice is clear.
Yes, everything is clear.
Thank you very much, and thank you for the invitation. My special greetings also to Professor Shetty for doing me the honor of inviting me to speak to this group. So my topic is, as has been advertised, and the plan is just to share my experience and my perspectives on multidisciplinary cleft care. Let me know if the thing is advanced. I'm trying to advance the slide, but it seems to be technology. Just give me a moment. So let me just stop sharing and share again.
Yes,
if you don't
yes.
mind.
I was going to suggest that. Yeah.
It's like, okay. And then share again. Okay, so do you see now?
Yes.
Okay, let me see if I can. The slides are not advancing. It's just yeah. Okay. Thank you. All right. So the outline of my talk is as present, as shown. Be a small introduction, and then we'll talk about what really happens when a child is born with cleft lip and palate. And then we'll show some of the clinical appearances of cleft. Then talking about how they are cared for in a multidisciplinary setting, in a team, and also share with you some examples of such a team work at my hospital in Ghana, Kumasi. Talk about challenges and opportunities and the way forward. So cleft lip and palate are the commonest congenital craniofacial anomalies which affect almost 1 in every 700 live births globally. There are local, regional variations. The cause is considered to be multifactorial. Between 20 to 30% are considered of hereditary origin, whereas the other 70% or more is considered to be of environmental origin. Now, when a child is born with cleft lip and palate, they may be associated with some medical complications, problems with feeding, growth, abnormal dental development, abnormal speech development. Hearing may be compromised, and they will have psychosocial and social challenges. So you need, of necessity, different specialists to be part of their treatment. And these specialists work best if they work together as a multidisciplinary team. It just minimizes the number of times the child and the family will have to travel to the clinic, and therefore the loss of time from work and school for both the patient and the parents and the child is minimized. And this kind of approach also, working in a team, definitely ensures that there's optimal function and aesthetics, and the child grows up in a more enhanced environment with self-esteem and social integration. So I'm not trying to insult anybody, but my briefing was that not everyone here is a clinician. So this is just to show you how cleft appears. You see that they appear in different types. Some may appear like just a small notch on the upper lip. Some may be a bit more extensive, approaching the bottom part of the nose. Others may not only involve the lip, but may involve the palate as the roof of the mouth at the same time. So that's cleft lip and palate. Other clefts also involve only the palate, as you see in this image. There are some that appear on both sides of the lip, and others extend from the lip to involve the eyes. Some involve the corner of the mouth, making the mouth look very, very big. Now, some clefts also are associated with a variety of abnormalities around the face and the rest of the body. So this child, you can see the eyes are pushed to the side, the nose is abnormal, the cleft is there. This child has got an abnormally shaped nose, widened nostril. This girl has got a abnormal upper limbs. This child has got a abnormal lower limbs. So this is just to show that cleft may not come as an isolated problem, may also be associated with other affections. Now, these are just pictures to show you some of the patients who have run through our clinic and how the fact that they ran through families. This woman came, she was born with a cleft on both sides of the lip, and she wanted her child's cleft lip repaired. She was happy with her own, but she wanted her child's repaired. So you can see that there's some something like a familial type of inheritance. Then we have this lady, her cleft lip was repaired, but she gave birth to a child with cleft lip. These two are like twins. Unfortunately, the male had his cleft repaired when he was a child, but the parents didn't have money to fix that of the girl. So when they were grown up, they brought these girls also to have the lip repaired. These are twins. One has a cleft, one doesn't. You're doing quite well, growing well. This one's development is a bit retarded. So families with children born with cleft and palate have, as I said earlier, psychosocial, feeding, medical, dental, and orthodontic problems, as well as speech problems. And the psychosocial problems relate to their appearance, and the children may be subject to teasing and bullying when they go to school. Families get rejected because they're giving birth to a child with this abnormal appearance, and sometimes some of them even get expelled from their villages. We have observed that many of these families have financial challenges. And if you can imagine a child who needs so many specialists to be able to get adequate treatment, then the financial problems can be exacerbated. They are stigmatized. Often there are family conflicts. You have mothers being accused of infidelity and being banished from the family home, or mother-in-laws asking their sons to divorce their wives because of the birth of such a child who they don't think belongs to the family. So, of course, they grow up with a very low self-esteem because they just don't look right. Feeding is a problem, and when a child is born with a cleft palate in particular, they cannot generate the negative pressure to suckle. Breastfeeding is a problem. The food that they take comes out through the nose. They're taking too much air, and therefore they appear full, but they've not had adequate feed. The development gets delayed due to poor nutrition. As they grow older, you see that the speech, because of the gap there, it becomes abnormal. We've seen some of the pictures of children with syndromes, but there are other medical problems that they have. They have stunted growth, maybe ear infections, hearing loss. They have heart, kidney, heart and brain abnormalities, as well as limb abnormalities. The teeth don't develop normally because of the gap that they have in the gum sometimes. And the front jaw, the upper part of the top jaw may be sticking out. There's protrusive premaxilla. Teeth may be missing. And the upper jaw, the maxilla, may also appear collapsed. And the teeth are generally not properly arranged because the gap in the gum does not allow them to have well-organized teeth like the rest of us who don't have cleft. They may be also prone to tooth decay, dental caries. So when you have such children, then they need to be assessed and managed in a holistic manner. And so a multidisciplinary team ensures that their feeding is taken care of, that their growth is monitored, and that they survive and that they can prepare for safe surgery. You also know that in such cases, they are being monitored closely, so surgical repair can be undertaken to restore function and the appearance. Speech therapy will be started. Orthodontic treatment will be started as when it's needed. And they will receive psychosocial support. and they'll be followed up in the long term to ensure there's an optimal outcome. So just to recap, multidisciplinary care, where you have different specialties coming together to treat these children, really aim to ensure that the children come out as best as is possible. Now, the American Cleft Palate Association has really outlined who should be part of this team. And in capital, I've put the child and the parent. Of course, they are the ones we're going to talk about, but they should be part of the decisions that are made about them. In addition to that, I have the speech therapist, nutritionist, orthodontist, geneticist, anesthesiologist, data managers who keep information on them, pediatricians, or primary care physician, surgeons, different types of surgeons, maxillofacial surgeons, plastic surgeons, pediatric surgeons, ENT surgeons may all be involved in the care of these children. Psychologists, social workers, audiologists, nurses, and then you may have a coordinator secretary. Now, you will find, of course, that team composition will depend on availability of specialists. So you say, going from one team to the other, while we have the ideal, in real life, in practice, the team compositions vary from center to center. But as a minimum, you definitely must have a surgeon, you must have a nutritionist, if you can get an orthodontist and pediatrician and speech therapist, then you are good to go. Of course, anesthesiologists will always be needed for the surgeries, and nurses. Now, how does it work, this team care? There are about 3 essential models for multidisciplinary team care. How the specialists work to ensure that the child is well treated. So you may have these specialists not located in one place, one center. So you have, and they may see the children in sequence, so independent of each other. They make decisions about the child. They decide this is what I need to do, and they plan the treatment independently. And then, like a conveyor belt, they press a button, the child goes to the next specialist. And so they also make their own decisions as to what the child needs. But they'll still receive the treatment, except that the specialists are not together. They are not planning together. Then you have another scenario where the specialists are all available in one location, and they assess the child together and then discuss their findings and draw up treatment plans together, and making sure that they coordinate review appointments and other treatment sessions. The third approach combines both. So you may have some of the specialists being available in one location, but others not being available, and therefore they have to refer the patients for them to see individually and independent of the rest. But in all cases, it is essential that the teams or those who are involved with the care meet regularly to discuss the patients so that they can do their best for them. Now, it is clear that if one has to see so many specialists, somebody must pay for it. And so the payment system in a particular setting influences the ability to achieve what we call the gold standard of care. So multidisciplinary team care is a gold standard of care, but it depends on how the care is going to be paid for. So there are countries like the UK and Sweden where there's a national health insurance system where a patient never has to think of whether they have money or not. when whatever that they need, everything they need will be taken care of. The clinicians are all paid for centrally, and their time is factored into the service they provide. So every child who will see as many specialists as they need to see, and they don't need to worry about the care. And then there are countries like most African countries where the user must pay upfront before they receive the care. And also in Ghana, we call it the cash and carry system. And this one is these settings create more of a problem for informing multidisciplinary teams, because somebody must bear the cost. And so in these environments, often there's a reliance on external sources other than government, maybe philanthropists, maybe NGOs, or patients have to pay out of pocket. So you can see that not only payment systems, but also there are cultural factors and the health system in general, the way it's organized, there's the availability of services, etc. They all affect the organization of these teams, multidisciplinary care teams. Now, when you have a team of so many specialists, you need to have harmony in the team so they can work together. Someone must be the leader. Someone must be recognized as a person who ensures team harmony. And this leader has to must be a fair person. They don't have to be the surgeon. They don't have to be the speech therapist. It has to be one who's agreed upon by the whole team. Person has to be recognized as a true leader who cares for all and who takes responsibility for the welfare of the team, as well as the functions of the team. There should be well-defined roles for all the disciplines who are represented in the team. And they must have legal accountability. So a surgeon cannot be making decisions for speech therapists, nor should a nurse make decisions for the nutritionist. So everyone must have a specified role, must be legally accountable for the decisions and the advice that they give. We should respect the expertise of team members, and like in any human setting, there are bound to be conflicts, and these conflicts must be fairly and expeditiously resolved. In all cases, the safety of the patient and the quality of care must be the only justification for having a member or a practitioner on the team. So if there's any concern about the quality of care provided by that team member, the team can make a decision to let go of that team member. But this is a discussion that can be had in the interest of the patient. Now, parents and patients and children are so important because really it's all about them. They know why they came there. They know what they're going through. And so they must be involved in the care. They provide feedback on what they perceive to be the quality of the care. And they also can make very useful inputs into treatment decisions. They don't always want to be treated, and they must be listened to. They have to make those decisions. And more importantly, they also bear the burden of care. So it is important that they are engaged and considered to be very, very important members of the team. Now, may not always, the team must grow. When you have a team, it doesn't remain static. And for the team to grow, you must have a succession plan for leadership. It's important that the next generation is trained, or specialists. And then that requires sometimes needing to have a needed infrastructure. You must ask questions about what you're doing, whether you're doing the right thing, whether your patients are happy. You must research must be embedded in the team work. You explore partnerships so that you have the best practice possible. And teams should go beyond themselves. They should also train others outside their sphere by building centers of excellence. Teams must engage in the difficult conversations, when a colleague is not performing well to satisfaction. But it's part of the fact that they must respect each other. Those difficult conversations must be had. And team members must appreciate the limitations. And it should be patient-centered. There should be a lot of openness. And as I've already said, regular team meetings. Team meetings are essential to be able to address problems and share in successes. So I just want to share with you the experience of the Komfo Anokye Teaching Hospital clinic. And we started our team in the year 2003. And a group of the pediatricians and a couple of surgeons, a speech therapist, and nurses came together, and a dentist and anesthetist. And we met weekly, saw patients together in this very small room, and this continued for a number of years. And then the room got expanded. We were relocated to about another place where we had 2 rooms. So we grew from 1-room clinic to 2-room clinic. In the course of that, we also observed that we needed to establish a foundation to support the needs of our patients. They had so many financial challenges. And so we established a Ghana Cleft Foundation in 2007 to support them. As I speak, the team has grown. And now we have so many other specialties added. We have pediatrics, nutrition, speech therapy, orthodontics, and dentistry, nursing, a number of surgeons, anesthesia, social work, health education, genetics, data manager, parents of children, of course. So we have grown. And this is on the picture on my left, and maybe also those you only have left as well, is really some of the founding members of the clinic in a small room. And on the right is a bigger clinic with a bigger membership of the team. Now, so these are some of the results that we get. We've seen several thousand patients since 2003, but just to show you that some of the results that we've been getting, we're getting some excellent results, and the patients we're treating so far are happy. So just to go back here, you can see that most of the time we see all our patients together. All the different specialties are there when we meet. Our clinic has grown. We've seen that beyond seeing them weekly, they have issues. Some of them don't show up. And so we send out a team, a social worker and a nurse and the driver visiting this family to follow up on this child and how they're doing. It's a senior social worker. So this is another one, a nurse visiting them at home, do home visits, and just to follow up on children that we haven't seen for quite some time. We've got, these are some more post-operative photos. I mean, the story with this one is a young lady who, she was about maybe a young Muslim lady, about 19 years. She had a cleft. And we did this. And the beauty of this story is that I think almost like 6 months after the surgery, she came to tell us that she was going to get married. So that's a story that we are very proud of. Now, we do, these are some of the children we see. We meet them every year. We organize a party for them. And for some of them, that's the first time they ever going to any party. But they meet people also born with cleft who have been treated or waiting for treatment, and they encourage each other, offer support. We have games and all kinds of entertainment for them. And it's not just them having fun. Some of our staff also join them in the dancing. We have some of our children have grown up, and we've established a choir, which has got two main benefits. Apart from the social benefit of the choir, it allows them to also exercise their voice, especially the children born with cleft lip and palate, and the cleft palate. Speech is the biggest challenge, so it's one way of practicing using the voice. Well, what are some of the challenges of team care? Consider that human resources remains a problem. Oftentimes, in many places around Africa, the focus is on surgical correction of the cleft. And this is because many teams start led by a surgeon. And even within the surgical field, we have surgeons fighting for dominance, so as to who should lead and who shouldn't lead. And so you may have maxillofacial surgeons, plastic surgeons, ENT surgeons, all wanting to lead. Generally, there are not enough non-surgical manpower around to staff multidisciplinary teams, especially speech therapy and orthodontics. They are very rare, difficult to find. And orthodontists usually do so well outside in private practice that they don't like to spend too much time doing these unprofitable jobs. But we have a orthodontist, we have two orthodontists who are very dedicated. Generally also, there's a general lack of awareness of the role played by the non-surgical groups. So that is some of the challenges we have in Africa. Infrastructure is another issue. There are not enough cleft centers on the continent, and we have very poor referral systems. So children affected with this condition often just get lost. They have to try one facility after the other before they get care. And I think part of the problem is also has resulted in an over-reliance on international NGOs who come for missions, missions once a year, 2 times a year. And so the children wait for them because they're going to get free care. And so the local services are underdeveloped. Unfortunately, politicians also love the free service they provide, so they wait for them. The out-of-pocket payments, financial challenges are there, and travel distances can be vast and costly for families. The lack of a national health insurance schemes also to cover all treatments can be a problem, and over-reliance on these NGOs. That these NGOs want the numbers. They want to do surgeries. The more surgeries they can fund, the better off it is for them, and it helps with the fundraising. So they're not likely to branch into other areas. I'm happy to say that I think Smile Train in recent times is branching into comprehensive cleft care. Our people also are not aware that beyond surgery, they need other treatments. So when you educate people, make them more aware, then they demand for better services. Now, this is a photo of a truck that was transporting people to the city where we live, and the family sent her this picture because the truck has broken down, and that it was the only truck that plies the route daily. So sent to tell us that he was going to be late or he can't make it on that day. So travel challenges, apart from the cost, are there. But there are opportunities also for increasing multidisciplinary cleft treatment. We can increase the number of centers where this cleft is provided across the continent. And we can do this if government deliberately adopts policies to support cleft care and actually invest in same. And investing in through training, through provision of infrastructure, payment. Partnerships, both local and international, for training can also be very, very helpful. And some of these partnerships can lead to provision of infrastructure, equipment, and payment for treatment. The use of technology can also make our life easy. Some of these are patients who have to travel to us for some of the services like speech therapy, nutritional advice, even post-operative care through telemedicine, and in collaboration with local health facilities, like smaller local health facilities. Some of the care could be provided from a distance. How artificial intelligence can also improve the care that we provide to patients is something that we must all explore together. But I believe that's a challenge for the next generation, and it's limitless. Allow me to blow my nose, I'm sorry. See. Now, training, we need to train specialists. I believe that, forgive me. Now, middle level cadre of staff can also be trained to support some of the interventions that don't need highly trained specialists. I believe that, as Africans, we really must do better and undertake regional cooperations better, continental cooperation. I believe that a lot of our problems can be solved just by pooling resources, creating centers of excellence where certain tasks can be done better. And it's something that we must explore. Okay. So in Kumasi, what we did was we had gained some experience in practicing multidisciplinary cleft care. So we collaborated with Ethiopia, with Seattle, with Nigeria to develop a curriculum for team cleft care training. And as a result of that, every year we invite a group of African cleft providers to come for 1 week where we learn about team cleft training. And we have grown we've since trained several teams from various African countries through the collaboration. This is a new building that we have. It's called the National Cleft Care Center or the Cleft Leadership Center, which was constructed through funding by Smile Train, which is an international NGO. Smile Train has been helping in our center by providing funding to support the surgical care of patients and some of the other treatments. And so they saw that we're doing quite well. We had several people come for training in areas like surgery, nutrition, speech therapy from all of Africa. So they said, let's help you establish a center of excellence. So this is a new center which was opened a year ago, which is accessible for all Africa. And we look forward to inviting and hosting some of you there, including the experts. You can come and train here, undertake training. So going forward, multidisciplinary cleft teams must be strengthened and increased through investments in specialist training. We need to address this issue of speech therapy and orthodontic shortage and expand the training. And maybe maybe be able to train dentists to learn some orthodontic skills so that they can support in this light. And maybe some nurses can also be trained as speech therapy assistants. Cleft care must be integrated into national health policies so that they are funded and they are captured in the budgets. Community education should to increase awareness of what is available should be also undertaken. And insurance systems led research. Multidisciplinary cleft care is a gold standard, and no one must deceive us otherwise. Just because teams can organize themselves and do surgery and go away doesn't mean that our people don't deserve more. They deserve more. And ideally, this care should be facility-based. Facility-based because a patient must know where to go to. There's a problem. If you organize a mission in a hospital and then you go away for a year to 6 months, where did they go to? There's complications, a problem, no follow-up. So we need facility-based multidisciplinary care as a gold standard of care. All the problems that we face belong to us as Africans, and we must face them. And I think our political leaders must speak about unity of purpose and cooperate better than they have been doing in the past. The opportunities exist for collaboration, and we must explore them. And we must invest in this in order for us to increase the outcome for our patients. To conclude, I'll say Cleft craniofacial team, the multidisciplinary team allows us to organize complex multispecialty care in a humane and cost-effective manner. The team approach reduces costs, minimizes school and work time loss, and promotes a more comprehensive view of care. It means a peer review takes place on a continuing basis, and we also learn from each other. So we need to really make sure that we all commit to this as a means of ensuring that our patients receive the very best care. We have satisfied families and satisfied patients. Thank you very much. Last slide. Thank you very much.
Thank you, Professor, for the excellent presentation. And really, congratulations to your work, you and your team, on the remarkable work you've been accomplishing in Ghana. And I hope this model can be replicated or adopted across many other African countries. Now I'm gonna move to the Q&A, question and answer session. So if anyone has a question, you can type it on the chat. I can see lots of upload, Professor, for your work. So
Okay, so
yeah.
that's fine. So you can read the questions for me,
If
and I'll be
someone
happy.
has a question, please type it in the chat or raise a hand. Yeah, I have one hand raised. Ted Mersch, you can unmute yourself.
Yeah, thank you very much. It was very informative talk. My question is really general, maybe not specific to your specific topic, but all the talk, all the publication coming out of Africa is always saying infrastructure, limited infrastructure. So what kind of infrastructure we expect to be the model to be self-sufficient? So I'm struggling to understand, there are better countries or less, infrastructure-wise, but we always talk about the problem of infrastructure or capacity in Africa. So can you enlighten us, what model are you looking to be, self-sufficient?
Okay. So thank you. That's an interesting question, and thank you very much. This is a health systems question. It's a very important question too. I believe that we have to get rid of our dependent mindset. Many African countries, we see a problem and we throw our hands up in the air. We need this, we need that, we need that. We don't have it, so we cannot do it. And I would say that we have to first start to understand the problems that we have and then strip the problems bare and see which part of the problem can we solve without a new building, for instance, or without the sophisticated equipment that we need. But if there's something that requires some sophisticated structure, then, and we don't have the resources, then we can begin to look for partnerships. And there are many, many partners out there. But infrastructure, well, we could talk about maybe buildings, equipment, and we can, I know, for instance, that there are centers that use certain facilities or certain items once and they throw them away. We can explore, can we use the second-hand equipment? But we have to be active and searching and look for what can help us solve a problem now, and then look for what we can solve in the future. But we should not give up. We should also not think that because we don't have everything, we can do nothing. I'm not sure whether I've answered your question, but it's a very general question. We just have to believe that the problems are there waiting for us to solve, and we must solve them. That's what I can say.
Yeah, thank you very much. That was very helpful response. So just in line that you mentioned the importance of, the value of team approach, but there's not much successful team formation and execution in most African countries, even the West. So it's not easy to build a team and that's functioning like the way you described the benefit of the team. So do you have any successful model how you construct the team and that becomes more successful?
Yeah, I suppose, yes, we have a team. And when we started our team, it was just a group of us met and said, you know what, we believe this is how we must look at our patients. We were lucky. We're all working in the same hospital, paid by the government. What we needed to do was to adjust our schedules so that we could meet at the same time once a week, and we did. So there's supposed to be some sacrifice. Sacrificing time. We had to agree on leadership, who was going to lead. And we also had to make sure that we listened to each other and respected each other. I think team building is a complex matter, but you can form teams. If the team needs money, the team must together look for the money, and the team must together and openly and transparently manage the money. So, but oftentimes some people are not as open. When you are not open with your colleague, they can see right through you, and they are likely to walk out. As we say in Ghana, they will vote with their feet. They walk away from you. So I think we all have a lot of learning to do in building teams, a respect for each other, listening to each other, knowing that everybody can be a leader. We just have to support. So I think it's it's harder to work alone than to build a team, but you achieve more with a team.
Thank you very much.
We have another raised hand. Please unmute yourself.
Okay, can you hear me?
Yes.
My name is Gabra Amlat. So thank you, Professor, for the delighted and informative presentation. So I do have one question. I think the cleft lip is a type of congenital anomaly. So the treatment and the prevention modality will be comprehensive like other anomalies. So how do you see the WHO proposal, which is universal newborn care screening at birth? Is it a good model of care to prevent the cleft lip also? I thank you.
Thank you. Cleft palate is formed between the fourth, or the face is formed between the fourth and the 12th week of conception. So waiting till the child is born, you've missed it. It's too late. You can detect cleft in utero. But what we aim to do is to prevent cleft by nutritional supplementation, advice on behavior, like mother lifestyle, environmental exposures, and stuff like that. So at the moment, based on our understanding, that is what we know, and also avoid through genetic counseling. Make sure that risks are minimized, especially if there's a risk of cleft running to the family. In our part of the world, is very a complex issue. If you detect cleft in utero, we don't know. We have no evidence to say that people would prefer to have the baby, the uterus, the fetus aborted. We don't know. But it's we don't advise that in our center. We just so you have to because it's so difficult to prevent. That's why we advise on the measures that we know are likely to help prevent the formation of cleft.
Okay. What about the preconception care and early time of antenatal care? Is it a good?
Yes. Early antenatal
modality?
care. Antenatal care, excellent. We advise that. We recommend that. You recommend that any woman who is expecting to be pregnant must visit the antenatal clinic early.
What about preconceptional care?
The what?
Preconception care. The care which is
preconception
given
care
before pregnancy, 3 months before pregnancy.
Preconception care is totally advisable. Perfect. Preconception care is best because then all the interventions can be had before that. I agree with you.
The other question, the following question I have, I agree. The other following question that I have is that nowadays, to avoid such outcome of pregnancy, there is fortified foods which is recommended for pregnant women. So do you have any experience on that?
No.
Folic acid, fortified folic acid.
Folic acid as a supplement, yes, but fortified foods, no, I don't know. Any folic acid as a supplement, yes. Food supplement, separate food supplement, but fortified foods, no. I don't have any experience with
that. Is this enough answer for you, Gabram?
Yes.
I don't have any experience.
Yes. Thank you
Any further
very
questions?
much.
Yeah. Okay. Thank you very much. I think we are running out of time, unfortunately. I only have one question. Prof, you mentioned in your presentation the AI or artificial intelligence. So do you think the AI-assisted facial phenotyping, those apps that currently used in genetic syndromes, would improve the early identification of syndromic cleft in African populations? Do we have enough data?
No, I don't think we have enough data, but I know of colleagues in Glasgow who are doing AI assisted phenotyping as a way of just helping to understand the whole complexity of cleft. But yes, I think it's something for the future that needs to be explored. Yes.
Okay. Yeah, I think in not only in cleft, in many other conditions, a lot of conditions, we don't have enough data. That's why we are encouraging more research, and that's actually the goal of this society. I have another question.
Super.
Yeah, yes, Prof?
Yeah, I'm saying super. Well
Yeah.
done, well done.
How do the epidemiological patterns of cleft subtypes differ between African regions and ethnic populations?
That's a difficult question. Like, you talk about the ethnic populations within Africa.
Yeah.
We actually don't have enough data there. We don't, and that is the real truth. I think we need to do more research on that. It's very risky to try and categorize ethnicities based on predisposition to cleft. We have no idea. There's a lot of speculation. In Ghana, for instance, there are certain parts of the country where they undertake illegal gold mining, where there are a lot of toxins in the food chain and the drinking water, and where it is assumed that the children are more prone to birth deformities. But what has also been found is that the ethnic mix in those places, because they are all going after gold, is so diverse. So we don't have any data. Yeah, we just know about the environmental exposure. They are exposed to the same risks, but ethnicity is diverse.
Yeah.
So
Yeah, I think we need more research maybe to answer this question, basically.
More research, yes.
Yeah. So I think we passed our allocated time by 2 minutes, but it's fine. But I would like to thank you very much, and we were honored to have you, Professor Donkor. And thank you for sharing your time and experience with us today. I would also like to extend my sincere thanks to everyone who joined us today and spared some of their busy days. I know everyone is busy in the afternoon, but this kind of engagement is what makes this webinar successful. So if no other question, comment, everything, we are concluding this session. Once again, thank you, Professor. So
and
for
thank you very
everyone,
much. It's a real pleasure.
okay.
Thank you.
For everyone, have a wonderful afternoon and goodbye.
Goodbye. Thank you.
Thank you, Prof, and goodbye.
Thank you.
Thank you, Professor. Thank you very much. Would you share as a PPT PowerPoint also, if possible?
I'm sure someone will do that. Yes.
The PowerPoint, yeah.